So welcome all. I think we've got some first attenders at the meeting today. I think Chris Gons is online. I think this is Chris's first meeting, and similarly Subo, first meeting as non-exec director with the Council of Governors. We extend a warm welcome to members of the public, of course, and our staff and volunteer colleagues who have joined us. As you all know from the national news, we're still in the midst of the COVID crisis, although we hope we're now coming towards the end. But the end may not yet be quite when we'd hoped it would be on the 21st of June. We still hope it will be in terms of being allowed to meet in public. So we are still keeping under review our public meeting arrangements because of the national emergency. We hope everyone is observing the regulations and having their vaccinations, and we hope that that will mean that we are all have more freedom on the 21st of June. But as I say, it's under review at national level, and we'll make our decisions regarding that in due course. Can I ask colleagues to please keep people on contributing to the meeting, keep the speakers on mute, please? That would be appreciated. And members of the public, if you don't mind keeping your cameras off as well, so we can keep the bandwidth for our so we can ensure we have a full and open meeting. If I may take the opportunity, I think that today this is Terry Parkin's last meeting as a non-exec director of CCAM with the Council of Governors. Terry's term of office ends at the end of August with the CCAM board, and I hope all council members will join with me in wishing Terry not only every success in I'm sure a very busy other careers he has lined up after CCAM, because there is life after CCAM and people do other things, although it can be all consuming. I just wanted to place on record not only my personal thanks but as of board colleagues. Terry has served this board with distinction for 2 terms of office. He's been with CCAM through his more challenging times, and I know has been a source of wisdom and guidance to my predecessors, but also contributing to board meetings in that time. He's been our subject matter expert on matters of adults and child protection. He's currently the link with the our wellbeing guardian and has been a champion of staff welfare and staff rights, as well as chairing the workforce committee as well in his time with us, and contributing to matters of education. So I think he's given a fulsome contribution to public life to CCAM. And Terry, I know you're going to be active in this meeting, and you will be active for the next few months, but a warm thank you on behalf of the council and the non-exec colleagues for what you have contributed to CCAM and to the public of the southeast of England. So thank you.
Thank you, David, and just a thank you to the governors really who were good enough to appoint me what seems like a lifetime ago, but it was 6.5 years ago. So thank you.
Yeah, thank you, very well said. And I think we will also should note that this is National Volunteers Week, when I'm delighted that we all celebrate the contribution of volunteers, of which the Council of Governors and our members represents that voluntary contribution to public life in this country. It's one of the great checks and balances of our society, and we have many aspects of the health and social care system where we rely a lot on volunteers, not only to assist with governance, but also to contribute to direct patient care and contributing to the interests of the wider public. And I think the COVID crisis has probably brought that to the fore and really brought it to great illumination, the contribution not only our governors have made, but also volunteers generally, and our community first responders are probably par excellence the visible part of CCAM in the community, but also the volunteer contribution. So thank you to all they've done and all of our governors continue to do. I think that concludes the introductory comments from myself. We've taken apologies for absence. Are there any declarations of interest? Anyone with a pecuniary interest or other interest in the matters to be discussed this morning? Thank you. I'll now move on to the minutes from the previous meeting and the action log on matters arising. So, Isabel, can I confirm the minutes first of all for approval? Colleague, are you happy that a true and accurate record of our last meeting? Okay, thank you.
Super. Okay, on the action log, there's one action that's due and outstanding, which was for me to update the code of conduct as per our conversations at the previous meeting and email it to governors. And I'm afraid I just haven't had time to do that yet. So that will carry over, but I'll get that done this month.
Thank you indeed. We move on to the Chief Executive's reports. Just to set the scene for this, the Governor Development Committee, as usual, met in advance of this meeting and discussed about priorities for discussion. And they certainly focused on the matters of staff welfare and well-being and our operational performance, which Philip is going to will obviously refer to in his report. And just to remind colleagues, the Development Committee does a really good job for the wider council, and just worth reminding governors the meetings are open to all governors to attend. So if you have any views about what should be on these meeting agendas, we really would encourage you to try and attend the Governor Development Committee. So Philip, your report, please.
Thank you, David, and good morning, everyone. I want to start with a couple of bits of recognition as well. So I want to thank the governors on behalf of the trust on the very wise decision to reappoint David Astley in his role. So thank you very much for that, and we're delighted as an executive and staff group that David's agreed to stay on to do a full second term. I want to, on behalf of the execs and staff, thank both Terry and Lucy, who both will have done their last meeting today, and Lucy obviously not here today, but for their contribution over that great period. And to note that we have made one appointment and will very shortly be announcing a second appointment to the executive team. So Emma Williams has now taken over from Joe Garcia as the operations director. And the second position that we have recruited for but not yet announced, we're still just finishing up fit and proper persons and due diligence and everything, will be for a director of planning and business development, who will work alongside Emma, providing Emma with the tools to run the operations part of the business. It's envisaged that the new director, whose name I won't give you for probity reasons, will start in the autumn, somewhere between September and October, but by the end of October. A couple of bits to update on that. It's probably useful for governors to hear from me firsthand what I think is happening with the pandemic. David mentioned it briefly. So the disease carries on spreading, and it is the story that I'm telling at the moment is one of the increasing spread of the disease at the moment. So we've gone past the low point. As the lockdown opens up, the disease spreads more widely, but it is not at this stage affecting people to the same degree, and that's simply a reaction of the people who are most likely to be most ill have been vaccinated in the vast majority. So that is holding. What will change that? There are two things that will change that, and that will be a big change in the sickness rates amongst the non-vaccinated, and forcing them to go into hospitals, or as the press are talking about all the time, so it won't be news to everybody, the appearance of a variant that defeats the inoculations that we've given people. So at the moment, all the variants, and they're now named after Greek letters of the alphabet, as you will have all heard, so I won't mention them by name because I don't know which one's which yet. I'm still calling them Chinese and Kent. But the all three of the vaccinations that we're using in the UK are pretty effective against those variants. But the appearance of new variants is almost a daily occurrence now. Not always appearance in this country, but appearance somewhere, which will likely spread to this country if they become the highest spreading, in the same way that the Indian variant has spread largely around the world. So that's the risk. The hope is that the race between vaccination and people getting these diseases stays in the way it is now. If that's the case, then we'll carry on with a slow relaxation. We, as a trust, will not relax as fast as the public, and the reason for that is that we're pretty sure that there's going to be a third wave. It will. The prediction is that it'll be. Last time I made this prediction, I was thinking September. I'm now thinking August because of the pace at which the cases are rising. The question is, how dangerous is the wave? So I'll leave it at that. But no doubt we will. Everyone will be keeping their eyes on variants and the effectiveness of vaccines over the next few months. In terms of staff, I'm going to do a special piece at the end about staff welfare. So I won't talk about staff welfare at this stage. I'll just make a couple of bits though. We have done a couple of things that are more normal. So we had some staff awards on the 20th of April. We did those online, and we are planning a face-to-face normal in-person with dinner staff awards for the autumn to catch up on all of those people who didn't have them this year, and to celebrate some of the remarkable achievements during the pandemic. So that's a good thing. Largely, our people are feeling pretty safe at the moment because the numbers are down. We are encouraging everybody to maintain distance. We are encouraging everybody to keep wearing masks, and we will continue to do that probably throughout the summer because we don't want to be the first ones to be affected by the change when it happens. So we will be taking a cautious approach to staff welfare in that sense. Talking about other staff, then let's talk. So the 111 system, 111 is now a really important part of the whole health system, because with the CAS, the Clinical Advice Service, and with 111 first, pointing people to hospitals or not, it's increasingly the place of choice to go to. We predicted. And we are funded for about 3,000 calls a day. Given all those three things, what's actually happening is that we're getting closer to 4,000 calls a day, so 25% above what we are staffed for. So the call answer rate is suffering quite badly. Obviously, the only answer to that is either doing every call more quickly or recruiting more staff to answer calls. What we don't want to do is take clinicians who are providing the really valuable end of the resource off doing that and get them to answer calls. So it's a balance that we've got to strike. But we're doing really well on the clinical advice part of the service. We've managed to maintain the service levels there, but it's just the call answer and the call abandonment where we're struggling because of that really high demand. And that high demand has been going on now for a couple of months, and doesn't show any sign of peaking. It's the same across the country, and it's in some ways 111 being a victim of its own success. In that sense. we'll continue to work on it. 999, we've got some interesting things. What we think we are seeing, and it's very early on for people to be exact, but everybody in the health system is looking at what's happening to demand and trying to picture exactly why what's happening is happening. But just a bit of a picture to the 999 demand. So our Cat 1 demand is 19% higher than it was the last time we had a normal year, which is a huge increase. So we're comparing it to 2 years ago rather than last year, because last year the demand was completely COVID affected. The year before and the year before that were pretty similar. And before that, it was we had different measures. So 19% is a huge increase. The Cat 2 demand, which is the biggest piece of our demand anyway, is also up by 14%. Cat 3 demand is obviously down, because if the other two have gone up, that one has to go down. It's got the rest of our numbers in. That's down 15%. Overall, it's a 7% increase. When we're funded for a 2% increase. But the fact that it's all in Cat 1 and Cat 2, and more than that in Cat 1 and Cat 2, makes it more difficult, because those are where we use more resources. So typically we will use 3 to 5 resources on a Cat 1, and so you can imagine the effect that has on availability to do the less less urgent calls. That's the core of our issue. So our workforce is pretty much where we expected it to be. The level of availability of people, trained people to do what we're doing, is pretty much what last year's plan said it would be at this year. Obviously we would like more. But we're in this period of growth that takes years, about growing the number of paramedics as they come in each year, and growing the workforce like that. And we close the gap by using private providers. Whereas the workforce is pretty much where we expected it to be, there are several things that are affecting us. Firstly, there's that mix up in demand, which is making it really difficult to get to our less acute patients, and secondly, the amount of leave that people are taking has gone up significantly, and that's because of you can imagine pent-up leave demand, and suddenly you start getting the relaxations. People are allowed to go on holidays, some abroad, some not, but mostly in the UK. So leave has gone up, and sickness, normal sickness, not COVID sickness, has gone up, and that is added to the relatively small number of COVID sick that has affected availability of workforce. We are running 2 different plans to recover that position, but neither of them. The first one is just about grip and focus, and that's on a 12-week cycle. And the second plan is about increasing the availability of frontline capability, and reducing the back office element to a degree to pay for that. That's a longer term piece, but if you want, am I promising that by a certain date that all of this will have settled down and we will be hitting our targets again? I can't see that. I don't understand what's happening with the demand well enough, and nobody else does. It's not just ambulances. The hospitals, typically a hospital that would normally take 300 patients a day into their ED, are now taking 400. So they've seen 25% increase in walk-ins, as well as those that are taken in by ambulance. So it's a whole system effect, and lots of people have said, oh, it must be primary care not doing their job because they're all coming to us. But primary care demand is similarly up, and so it's just the reaction to what has been a year of people holding on to their illnesses, we think, and that is people going later. So when they do present, they're sicker, which explains the ambulance demand, and otherwise it's just more people suddenly going, yes, okay, I now feel safe to go to an A&E and stand in a queue. That is making our early summer more difficult than it normally is. Normally we would be performing relatively well at this stage of the year. We always have a dip in July, so we're planning ahead for that dip in July, trying to get ahead of that curve, so that because we don't want it to get worse than it is now. But it's a hard act to follow. And what I suggest, Chair, is that I think we have at the next board, we don't normally invite other directors, but I think it would be worth having David, the Chief Operating Officer, or Emma to come along and talk specifically about this as a one-off topic, because it's going to be an all-year event, so it won't. It'll wait. So let's move on to staff welfare. Where do I look for staff welfare? The indicators of staff welfare for me are all covered in the sort of day-to-day reporting of figures into me, and I'm trying to add everything up together and say, how does that feel? So that obviously the first thing is, have we got a staff welfare system that works? And we do. And I'm still proud to say that we have I think the best staff welfare system in the ambulance service. I don't know the rest of the health service, but I've certainly compared it to other things in the health service. So did the CQC, and our staff. The service that we provide to staff is not 100%. Of course, it's not. But it's better than most other places where you do similar work. But that doesn't solve it, because the problems are still there. So where am I looking? I'm looking at the number of staff that we've got shielding. So that means they are really vulnerable. And we had at its peak, we had over 60 staff shielding. All of those are now back in the workplace, apart from one. So that's a good sign. In terms of the amount of staff who are off work with COVID, that's running below 50. If you remember, at its worst, it was in the 500s. The normal rate last summer was about where it is now. So today it's 37, and that includes a number of people who can't come to work because they've got long COVID. So long COVID, just a reminder, what long COVID actually is defined as. It's you had your positive test, and then 3 months later, you are still suffering the effects of the illness to a degree where you can't work. That is defined as long COVID. So we've got a number of staff, some of whom are back in the workplace with long COVID, but only doing part-time. And we're giving everybody phased return to work as they go through it, and it's different for every person. But that's one indicator, so I'm not too worried about that. It's about the low at a reasonable level. The level of vaccination is the next one. So how safe are we as a group? So we're 83% vaccinated, and that will go up a tiny bit more before we close the vaccination centre on the 13th. We've got about another 70 staff who are due to have their second vaccine. So that means we've got a pretty good chance of escaping or of getting our staff getting really ill when the next wave comes. The difference between us and someone who's normally just doing their daily business is, if you get a third wave and they start to become hospitalised, our staff will get much higher exposure because because as the hospital gets blocked up, you spend longer and longer in the back of an ambulance with a patient who's got the disease. So that's why we will be more cautious than everybody else. But it's a good number, that 83%. It does hide some variances. So some young people are less well vaccinated because of their choice, not because they haven't been offered it, and our BAME staff are less well. They're about 60% vaccinated. Again, no matter what we're doing, it doesn't change that number very much. But we will continue to provide vaccination even after our vaccination centre is closed. We'll do that through the general vaccination centres. So what other aspects do I look at for well-being and welfare? So our retention rate is another place where I look for indicators, and that's over a year, over the last 12 months, that's running at just over 10%. Normally, it's about 15%. So am I going, yay, we've done a really great job? No, what I'm saying is I don't know exactly how much of that is because of the general employment scenario and the COVID effect. But it is better than it is normally. We certainly haven't got a rush of people running for the door. Our sickness rate, again, our rolling sickness rate is higher than it is in other parts of the NHS. It's running at 7% last month. And so that's about average for this time of year. Our target is 5%. We'd like it to be lower, but is it something that is worrying me to the extent that I think we've got a malaise of some form? No, I don't. When I look at the causes of those sickness, the two most significant causes are the two that you would expect them to be, and that is musculoskeletal, because of the work that we do, and secondly, mental health, because of the type of work that we do and the people that we attract. So those are the two highest. They're about equal first, and so we need to just keep our eyes on those. How many people are taking leave? This isn't an indicator of well-being as such, but if not enough people take leave, it's a thing that will affect their welfare and well-being over time. So in April that was low, and we did a bit of a push on that, and I'm glad to say that in May it's back up to our seasonal norm, despite the lockdown. And that's again a sign probably of people wanting to get away in the UK mostly, although some people are in Portugal, as we know. In terms of meal breaks and end of shift overruns, they're running a bit hotter than we would like at this time of year. So it's about 50% of our staff are getting their meal breaks in the window that they're designed to get it into. We've done some good work on that to take away the effect on it. What's good for this time of year? Normally we would want that I'd want that to be in the 70s or 80s at this time of year, so it's quite a way down. But that is the sign of that additional the additional ask that's being put on the service. And lastly, the violence and aggression. Have we got a whole bunch of people who are either being violent and aggressive to each other within the service, or is there a significant spike of other people being violent and aggressive towards us when we go to help them? And the answer is there was a spike. It's settled down to normal levels, but it is too high. The internal violence and aggression it hasn't spiked, but it rumbles along at a level that I'm not happy with. So of course we're working on that, but it's not showing a spike. It's not showing an uptick. And of course, everybody who's listened to yesterday's news will be aware that we're running a pilot on body-worn cameras to see if that affects either the well-being of staff or the feeling of well-being caused by the fact that you now have the ability to capture some evidence as opposed to it being one word against another. So overall, what's the picture of staff welfare? It's a remarkably resilient workforce that we have, and there isn't something that is shouting out to me that we've got this massive wave of mental health or other illnesses being caused by the extraordinary events of the last year. But like all of those, every indicator that I've talked to you about, of course, we'd like them to be lower. So it remains a serious priority for us as a board and as an executive team, and for all our line managers. I'm going to stop talking now, David, and hand over to questions.
Thank you, Philip. Colleagues, any questions of the chief executive for his report? And hopefully I've picked up the issues which the development committee wanted highlighting, particularly around performance and staff welfare. But governors, do you have any questions you wish or points you wish to clarify at all?
Jeff's hand is up.
Yeah, Jeff.
Thank you. Yes, Philip. One area that I think myself and some others within the Council of Governors would be aware of is the issue of CFRs no longer being sent to care homes, or still not being sent to care homes. We're wondering why this situation still exists, because obviously that has an impact on the response time to those locations. If you've got a CFR who's literally 2 or 3 minutes away from that care home, and they're getting called out and then stood down, and crews could be 15 minutes away.
If I'm honest, Jeff, that's the first time I've heard that. I don't know why that's still the case, but I will find out and I'll come back to you, and I'll come back to you as an individual, but I'll also report back to the council.
Thank you. That would certainly, as Jeff says, that might improve the margins, response times. Yeah,
and anything I can do to improve. You know, there's obviously a safety issue, and I can only think that someone thinks there is a safety issue there. Otherwise, we would have gone back to it. But thank you. It's a stone that we haven't unturned, and I'll now do so.
Okay, my suspicion is it's a low priority item and has got pushed to the back of the queue, and no one's actually looked at it and said we can reverse that decision at this point in time.
Yeah, I'll check.
And care homes do have, I think, in my experience, on the board of a care home, there's also issues about the care homes restricting access to those people. So we'll certainly have that checked out. So action with Philip. Harvey?
Philip, you mentioned that we've got 83% people vaccinated. Is there some idea as to whether that is more or less in, shall we say, the direct public interface people, i.e. those who go out on the trucks, etc., as opposed to those who are office based?
Yeah, so it's about 86% of our frontline staff.
Okay, so that's encouraging. Thank you.
Thank you.
The explanation of the rest of the number is quite complex, but it's only about 4 to 5% who are saying they don't want it, which is still 4 or 5% more than I'd like, or that I personally understand. But that they are normally quite well read, quite passionate, and they're the same people who we have the annual argument about the flu jab with. And they say, I've never had flu, and I've never had the flu jab, and so why would this be any different? There are, and the rest of the number is that those people who can't have it because of conditions that they've got, the fact that that's the stage of pregnancy that they're in, etc., etc.
Thank you. Question from Chris. Thanks, Harvey. Question from Chris Gond.
Thank you, Chair, and thank you very much, Philip, for your presentation. It was an excellent presentation. I just wanted to sort of bring you to some of the figures that you talked in terms of the increase in the workload. You know, you talked about Cat 1, 19%,
yeah,
and an increase of 14% for Cat 2, and a reduction of about 14% for Cat 3. Now, my question is that overall there was a 7% increase in terms of demand. I mean, did you actually budget for that increase? And if not, I mean, are you getting extra support to ensure that the service is not marginalized in any form or shape?
So our commissioning arrangements were based on a 2% a year, 2% annual increase. So that works out at 4.2%. So we have 4.2% more money and a 7% overall increase. So 3% of that has not been funded, and it's a question of going into it because we haven't had a financial planning round for 2 years now. So we're just going on block contracts, which are based on last year, and with a small increase. So we will be having a planning round at the end of this year, and that we'll try and make up for that underfunding in those times.
I think it's fair to say that certainly the Finance Investment Committee are well aware of the potential risks to our financial situation and are working with the executives to make sure we've got there are clear plans in place, and that we're beginning to look at our cost base. And I think that really brings into very firm focus. We do have to be financially well managed, and certainly my non-exec colleagues are very much onto that, and with you, Chris, through the Finance Committee. So I think it's going to be a very important part of our work over the next few months to make sure we keep control. Any final?
And welcome to your first meeting, Chris.
No other hands are up. So
David,
right.
If I could just make a final comment about Volunteers Week. There are a couple of the governors, a lot of the governors who do extraordinarily wide ranges of things. So I just wanted to mark that. I'm going to use one very small, one example. And I only use that one because it was on the internet yesterday, so I know that he's not shy about it. But I do recognise that all of you are doing more than one job as a volunteer, and lots of people are doing extraordinary amounts of things. But I was really taken by the social media coverage of Lee Westwood's daily work rate, where he appears to be a full-time employee of an aircraft company, a governor, a CFR, and about 4 or 5 other voluntary roles that I couldn't do in one working day, let alone every working day. So I know you're all doing that, and so it's a good week to celebrate you all.
Yeah, well said, Philip. I think we all echo that. Well done to Lee, but to all of our volunteers who contribute in the way they do. It really is a real eye-opener, and certainly was to me when I was involved with ambulance services. I knew volunteers made a huge contribution to the NHS, but the role of volunteers in the ambulance service is often does not get the widespread publicity that other parts of the service do. So I'll say a warm thank you. And just an apology from me. I should have at the beginning of the meeting also welcomed Paul Brocklehurst to his first meeting as a non-exec director as well. Paul has joined the board recently after one of our, again, thorough recruitment processes. So welcome, Paul, and welcome to the council. So we're banged on just 2 minutes behind time. Moving on now to the assurance from the non-exec directors, and we have the integrated performance report, which is a comprehensive document that's in your pack. Now, just to be clear, this is there for your information. We have escalation reports later on in the meeting, so each committee can in turn refer to matters that's relevant to them that's featured in the integrated performance report. The data in that report is to the end of April, but at this point, are there any questions of clarity on the data that we shared with you. So comprehensive pack, which is under refinement, and my non-executive colleagues are working with the information team to make sure that that document is fine-tuned. So first question, I think, from Jeff.
It's a simple one in maths, which I've looked at the current operational performance, the numbers of C1, C2s, etc. And then we have, at the end of it, we have a count of incidents and count of incidents with response. But nowhere can I get the number of incidents via the various categories to actually come to the same number as the count of incidents and the count of incidents with response. So I just wonder how these, do we know how these numbers actually get together?
You're on mute, I think.
The numbers, Jeff, are provided by our business intelligence team from from our from the EOC data, but I'll have a look at those and see if there's something going on there, and I'll go back to the business BI team and see what's going on.
Yeah, it should be clear to you, Jeff. I mean, there should be no mysteries in his report, so we'll certainly need to do some reconciliation there. Philip, can you comment?
Yeah. So we get. I'm just looking at the month-to-date report that's in there. 4,000 calls into the EOC. 4,100. Sorry, 41,000 calls roughly, yeah. Translated into 36,000 incidents. So that means that about 5,000 of those incidents had more than one call related to it. So it's either multiple people calling about, for example, a road traffic accident. You always get a lot of calls for a road traffic accident. So that's where some of those calls go, but they also, where we are slow to get an ambulance to a patient, they might be repeat calls. So those are people phoning up to say, any news about where the ambulance is. So that's the difference between calls and incidents. The difference between incidents and incidents with a response, the majority of that difference is hear and treat. So that is the number of calls that are dealt with by call handlers. So that's about 2,700, which, when you add that on to the calls of incidents with a response, gets it pretty close.
Yeah, that's those ones I'm not so worried about. It was when I look at the count of incidents with a response, I don't see how we get to that 33,600 when you look at the actual C1, C2, C3, C4s, etc., and add those up. They don't actually come to 33,600.
Okay, we clearly need to explain that. So can we take that away, Philip?
Yeah, I think they're pretty close.
Yeah.
Looking at it.
Yeah. Well, Jeff is applying the eye of detail of the public.
I'll get someone with a computer to check it, but but if there's an issue, or if it's not exactly right, I'll find out why, because it shouldn't. And Jeff, you're quite right to point it out. If it's different, and you've actually spent some time with a calculator, then that's a mistake, because it should be the same.
Yeah, well, we have a few people with calculators, so can we ask them to go and check? Thank you. Well spotted, Jeff. Can we move on? That's any of the final points of clarification. We'll pick up the matters of detail in the committee escalation reports. Thank you. The next item is really for the information of the wider public. I know this is well known to members of the council, and particularly the nominations committee, but just for your information, we do non-executive directors are accountable to. We're accountable to the council of governors for how we perform our duties. Not that we're appointed by the council, but we are accountable to them. And we are held to account for the work that I and the non-exec directors do. So we do have an appraisal process in place, which which will be reviewed in detail in part 2. So colleagues know that we're all subject to appropriate scrutiny and challenge for effective contribution to the board. So there's the paperwork that we summarised for you, just the process that we do go through, which, like the executive, there's an annual round of appraisal, but also objective setting to ensure that we're all accountable and working in the wider interests of not only CCAM, but of the NHS. So that's hopefully that's all clear. Is any point of clarification? I think it's important for the public that people do realise that these aren't sinecures. People aren't doing it just for representation. Some real work goes on behind the scenes, which non-exec directors contribute to the workings of the board and or held to account. Okay, thank you. Let's move on if we may. We've got the membership, the verbal update from the membership regarding membership. Brian Chester, item 1321.
Yes, thanks, Chair. A verbal update because basically the MDC meeting, which was scheduled for the 4th of May, has been postponed until the 22nd of June, and it will take place then on the same day as the Governance Development Committee meeting. So Katie, our membership manager, has been off sick, but I'm pleased to say has now returned on a phased basis, and I see she's actually observing the meeting online today. So Katie, welcome back. Good to know that you're feeling better. And actually, but please don't be too heroic. Make sure that you take things easy on the way back in. And you don't need to comment on that, it's fine. COVID restrictions really means that we haven't done an awful lot in terms of membership recruitment and events in any case. And COVID has also caused a number of changes to the sort of schedule of some of the constituent groups within the MDC fold. But since the last council meeting in March, the Staff Engagement Advisory Committee has moved its meetings back to a quarterly basis due to increased workload within the Learning and Organisational Development team, and reduced attendance from representatives actually each month. And I think we've heard earlier about the impact on some of the staff in terms of workload, etc. There is a meeting planned actually for the end of July, which is designed to be used to capture any staff feedback from across the trust and bring this to relevant areas within and relevant people with actually in the trust. And in the meantime, they're going to be starting a wider work stream around what staff engagement looks like within the trust currently and what it needs to be, including reviewing the purpose and effectiveness of the actual committee itself. So I guess we do that with most committees as part of our regular review, so it's not bad to be doing that anyway. And over the last quarter, there has been discussion within that group, looking at the Made at CCAM leadership development content, staff survey, engagement and learning plans, and reward and recognition within CCAM. So sure, more of that will come along later. The Inclusion I advisory group hasn't met since January, and the council received the report for that actually at the last meeting, and the next meeting will be in July. So looking forward now to our 22nd of June meeting, and actually having Katie back on board, that's when we'll be planning the annual members meeting, which is due sometime actually in September. And I'm guessing, again, probably very much an online meeting on this occasion, although we were looking at one stage as to whether we could do a mix of online and face-to-face. And as I said earlier, actually, the meeting 22nd of June is the same day as the GDC. We discussed within the groups the idea of perhaps getting a higher attendance from governors if we hold those two meetings on the same day, because roughly speaking, each takes up half a day. And whether it's a question of actually when we're travelling together to a meeting when we can, or whether actually online, it might help governors and improve attendance actually if we were able to get through two meetings in a day like that. for some governors I know, Nigel, who's not here today, is one of them, when they have that heavy commitment that Philip spoke about, there may need to be some adjustment if we start to change the schedules, because people do actually plan meetings 6 months or 9 months, or plan diaries that far ahead. So I think looking back, that if we do that, we need to have some cognizance that 1 or 2 governors may be missing from meetings just because of a clash of interests. Now, the one group I haven't mentioned yet is the patient experience group. Actually, haven't had any feedback from their managers. But Harvey, I know that there actually was a meeting on the 20th of May. Could you give us an update on that, please?
Yeah. They did meet on the 20th of May. It was the first one for several months. It was a reasonably positive meeting, and a number of things were promised. We know that the strategy was signed off back in June 20, and also there have been drafts of an information leaflet, which we saw several drafts of some months ago. Unfortunately, neither of those have actually yet arrived with either Nigel or I, who were the governors, so we can't comment on those yet. There was some discussion around measures, and that was quite useful, but it's still unclear as to how we'll measure patient experience and how we bring together the measures we've got. Certainly, we recognise that there have been huge pressures on the people, the sort of operational people, and of course just recently the QA report has diverted attention from anything around this. We've got a workshop the 29th of June for patient experience. Yet I'm a bit unclear as to exactly what that's going to address. There are obviously a number of things it could address, and we've got another meeting planned for the 15th of July. But at this stage, it would be wrong to say that there's been a great leap forward or anything like that. So that's where we are.
Fine, thank you for that, Chair. I think from the verbal report in general, happy to take any questions, but otherwise on with the next part of the agenda.
Thank you, Brad. It sounds there's some items to the Quality and Patient Safety Committee to pick up from Harvey's report there in terms of patient experience. So I'm going to ask Isabel to keep a note of that, and we'll make sure that's followed through by non-executive colleagues.
Thank you.
Any other questions of Brian? Okay, thank you. We can move on then to item 1421. I'll hand over to Nikki, our lead governor, for the Governor Development Committee report.
Hi, thank you, Chair. Hi. Okay, so the Government Development Committee got together to look at our effectiveness and our terms of reference. So with our effectiveness, we looked at the annual review of effectiveness via the self-assessment, and we agreed as a group that we would continue using the same survey that we used last February to keep continuity. So we were having the same data that we could compare against rather than introducing a new survey, so we could see how effective we have been pitted against the survey from last year, so we could provide that comparable data. The terms of reference, again, reviewed annually to make sure it was fit for purpose. The document had some minor changes with the addition of the provision for video conference calling, because obviously with the pandemic, conference calling as we are today has become the norm. Alongside governor attendance at council meetings, looking at how many times a year a governor is presenting at these meetings, and the Government Development Committee and all the other subcommittees that we do have. Is there anything you wanted to add to that?
I'm just looking at my notes. I think you've covered most things. There was, are you going to cover the GDC's review of its own effectiveness separately?
You can. I haven't got the note for that.
That's cool. So you've covered the changes that are suggested for the terms of reference, and this the council need to approve those, Chair, if that's okay. Unless anybody's got any questions about those. And then also the GDC reviewed its own effectiveness, as it does every year, and basically it thought it was doing all right, which is good. Excellently chaired, of course, by Vicky. But highlighted that we had a lack of attention in our agendas to governor training and development, so that's going to be added as a standing agenda item, and also noted that mainly due to COVID, quite a few actions on the action log had yet to be addressed, so we need to work harder on those as soon as we're able to. So that was it. Thanks, Nikki.
Thanks, Izzy. So that's all that is under the GDC effectiveness and terms of reference. Chair, I don't know if you want me to go on to the governor activities and queries report. I know that the non-com was in front, but if you just want me to carry on.
No, we'll come back to that. We may. We'll come back to the governor activities report after the next item. We may, Nikki, thank you. Just in terms of the point, what I'm hearing though from what Nikki's saying, and I think Isabel, there's probably time for a post-COVID clear out, as it were. One or two items hanging over because of COVID have been held up. We need to take stock, I think, probably later in the summer when we've got some semblance of normal working. Just have a bit of a clear up of the action lists and see what was relevant to take forward. If we may. Okay, thank you. Just to move on, if any questions of Nikki's report? Can't see any hands raised thus far. Okay, let's move on then to item 1521, which is the nominations committee. There's two main items: review of the effectiveness of the nominations committee and revisions to the terms of reference. And as Nikki's outlined in relation to the Governor Development Committee effectiveness review, we did a similar review within the nomination committee. What's been a busy year actually, recruitment of non-exec directors in particular, being that we do have very strict standards to maintain of inclusiveness and to ensure we run a thorough recruitment process. By necessity, the recruitment therefore takes time. It's appropriate we do that, but so there's been a significant amount of work in the last year for the nominations committee in securing some very high quality appointments to the non-executive team. And I know that Brian, Waz, Nikki and Jeff in particular have made a great contribution there to giving their time up without question to that recruitment process, as have other members of the governor team, to ensure that we make good appointments. So that we are very grateful. And we also reviewed our terms of reference, which are presented with track changes for council to approve. Hopefully you will do that in a moment, but the changes are quite minor but important. Just to summarise, recognition that it's hard to find an appointed governor to join the nominations committee. This is to almost replace the irreplaceable Graham Gibbons, who served the council extremely well for many years, representing local government colleagues. We're doing our very best, and in consultation with our local government organisations, to find a replacement for Graham, but we haven't not yet secured that. But it's no longer a strict requirement for membership of the non-com, but we will do our very best to secure a replacement for Graham. We've made an addition for the provision of video conferencing, which is going to be a feature of all of our lives going forward, whatever the outcome of any review post-COVID. And we also felt we should be mindful of the Nolan principles of public life and their own values and the importance they are to non-executive recruitment. So we've also amended the terms of reference as appropriate. So, colleagues, are you happy to approve the revised terms of reference? I see some thumbs raised and sort of approval, and no questions or sign of dissension. So I think we can take those as approval. Thank you. And if any of the appointed governors present would be interested in finding out more about the work of the non-com and joining his work, please make contact with Isabel, and we'll be happy to welcome you. So hope you receive that report. So thanks again for all the work the Nominations Committee do. Moving on to 1621, which is the Governor Activities Report. So Nikki.
Hi, thank you very much, Chair. Okay, so the Governor Activities and Queries Report captures the membership, engagement and recruitment activities of our governors, and this includes training and learning about what we've participated in. So due to the pandemic, obviously things have been halted. We haven't really been able to get out to our constituents at all, really, because we haven't been allowed out. One of our governors has made it to two things in the past couple of months, which is wonderful. Marcia attended the Gender Equality Network launch and the Agile Working Workstream, which ensures effective communications and engagements on behalf of staff and Foundation Trust members. So well done for Marcia for getting out and actually flying the flag for us. We're in this quite difficult time. We've had a few queries and information requests come in, mainly around COVID and staff wellbeing. Just to pick one out is just understand how the staff have been impacted by COVID-19 and how many staff in each of the main areas and how many are suffering from long COVID, which obviously was spoken to about by Philip this morning. And that was the main essence of the queries that came through, was about the impact on staff of COVID. So that's really it at the moment. Until we are allowed out and we can see the people that we're serving, there's not much to report.
Thank you indeed, Nikki. Colleagues, any questions? Brian?
Can Nikki or Isabel actually, I think it might just be an idea to recirculate the form around governors as we open up again in terms of reporting. And I know I, for one, actually am remarkably poor at actually filling the form in anyway. So I just actually encourage us as we move forward again to actually to give that feed, because that where you're sat, Nikki, and trying to do that with the activities, it's difficult at times. People are active, but it's actually just spending 5 minutes to let you know what they're active doing.
Absolutely. And I'd totally encourage everyone to go through the link. It is on the report. The link is embedded into the report, but I'm sure Izzy can recirculate it for us.
Absolutely. Thanks, Brian.
Okay, thank you. Can we now accept the activities report? Thank you. If we move on to item 1721, which is the External Audit Working Group Terms of Reference, and just to clarify, governors work alongside the chairs of our Audit Committee and Finance Committee to manage the tender process every 3 years for the appointment of our external auditor. And very important process where we, again, part of the checks and balances of public life in this country. All organisations appoint an external auditor to bring external scrutiny and expertise to our working, to make sure that we are open to challenge and that we're not only using public money wisely, but we are well governed as well. So this complements your assurances, the Council of Governors and of others who review our work. So the terms of reference to the working group, which consisted of Michael Whitehouse, Howard Goodbourne, Brian Chester and Harvey Nash, are presented here for your approval. And also, are there any questions before we move to approve the terms of reference, and any of the contributions either my non-exec colleagues or Council of Governors wish to make this matter? Michael, are you content? I've summarised the role of the external auditors appropriately. Thank you.
Yes, excellent. It's a standard procurement that we have to do, and we're making good progress. So thank you.
Okay. Now, take that. We can approve those terms of reference. Thank you. We now move on. Actually, we're ahead of time, slightly ahead of time. So this is when I think, Isabel, we'd scheduled a comfort break.
Yes, I think we should have. I think I just noticed I can't see one on the agenda.
Do I release people for a break just to check that we covered all the items we should have covered in the first section of the meeting?
Yeah.
Okay. So, colleagues, can we be back at 11:20, please? I'll give you 12 minutes to refresh. Right, it's 11:20, so we shall resume. We then move on to the performance and holding to account section of the meeting. So item 1821 is the Board Assurance Committee's escalation reports. With the first escalation report we're taking is from the Workforce and Wellbeing Committee. And we just as well the week to note we've got a deep dive into the work of this committee later. And when you'll be able to ask a lot more detailed questions. But is there anything at this stage, Laurie or committee members wish to bring to this attention? So we will be giving this matter some attention later. But Laurie, is there anything you wanted to highlight at this stage?
No, I think I'll deal with it in my report of the committee later.
Yeah, colleagues all content with that? Thank you. We've now got the 3 sets of minutes from the Quality and Safety Committee, and I think it's fair to say that this committee has been particularly active in recent times, not necessarily so because of the fast-moving pace of the COVID epidemic, as well as having to just make sure that normal clinical standards are maintained, and they've worked diligently to do that. I'm not sure, Isabel, has Tom managed to join us at all?
No, he wasn't able to, I'm afraid.
Okay, but a number of us are members of QPS who are present on the meeting here today, including the Chief Executive. So are there any questions that members of the council comment on the work of the QPS? Say 3 sets of minutes, have some detailed stuff in there. Is there anything you particularly wanted to ask of non-executive colleagues in particular? Marcia and then Harvey. Marcia.
Thank you. I've got 2 questions, if I may. The first one is how sure are the NEDs that we are running a safe service despite our poor performance? And the second question is about the public access defibrillators information. I couldn't quite understand it. So I understand that we're sort of responsible for the maintenance of some of these defibrillators, but the impression that I got there's some problems with the process. So I just wanted to take assurance that those defibrillators are in working order. So if someone is going to use one of the defibrillators that we are responsible for, they are going to work properly. And those are my 2 questions. Thank you.
Just perhaps in relation to safe service answer, I can start, and other non-execs I'm sure will contribute as well. But just to reassure you on that, in terms of, I know Lucy as chair of QPS has been, and then Thomas, since he's taken up the reins of that committee, have been very assiduous in making sure that normal business is maintained. So you'll see reference to the fact we do look at everything from complaint response times, infection rates, hand washing procedures, a whole range of things that would be normal business, whether we're involved in a COVID pandemic or not. So through and particularly with response times, we're very mindful of the pressure on our service. So again, we have sought assurance regarding the representation that we're maintaining a safe service within our EOCs. So have we got sufficient clinicians on duty? And again, we've taken reports on that, and we've seen a pleasing increase in the number of clinicians who are providing valuable backup to our operational staff in EOC, as well as to the frontline staff as required, with a whole range of health professionals. We've integrated the 111 service more closely, particularly with the prescribing system that was recently been introduced, as again further assurance and backup to our 999 service that they're working closely together. So I think that through the minutes, Marcia, I think you'll find as the non-executives have given a lot of scrutiny to this. It's been very much in the forefront of all my non-executive colleagues' minds. Clearly, well led and encouraged by Lucy as well in this point as chair. But my non-executive colleagues, those are members of QPS, have you anything to add in terms of the headlines I've just summarised, in terms of ensuring a patient service, safe service?
Terry's got his hand up.
Terry?
Yeah, just to reinforce what you said, David, and to give some more specifics in some ways. So in terms of the safety of the service, throughout the autumn when there were particular challenges and going into the start of this year, it felt like QPS was meeting almost weekly. We weren't, but that's what it felt like. So there was a very significant degree of scrutiny. I think you'll see elsewhere later on in the year when you get the reports around QPS and the QPS meetings, and I think it might have actually been in the last governors' meeting where you had an overview of the number of meetings. The degree of scrutiny that the execs have been under from QPS has been not insignificant. And I think we've been incredibly impressed with just how diligently people have worked to secure a safe service. Philip at the beginning was talking about the very significant increase, though, in business that we're neither funded for nor resourced for, yet we've still managed at times to meet all of our performance targets. So no one would suggest that we're meeting all of the ambulance response targets every hour of the day. I think what is incredible is just how often we have met them, given the particular pressures the organisation has been under and that the communities we serve have been under. But perhaps, governors, the one thing you need to know is there's been absolutely no complacency, I think, either from QPS or from the executive team around this. I think it would be right to report just how hard and how impressed we've been at the work rate of executive colleagues and their reports and colleagues across the organisation. And so we shouldn't be surprised, really, because I think we've come to expect that. But I think in terms of safety, Marcia, it would be hard to know, given the constraints we've been working under and the workloads that colleagues have faced, it would be hard to know what more the executives said their reports could have done.
Thank you. Subo, I think you wish to make a point. You're also a member of QPS.
Absolutely. Thank you, Chair. I think I can speak perhaps as a new member of QPS, and one of the things I'm reassured about is the amount of scrutiny that actually goes on at QPS, and there is an enormous amount of it, quite a lot of detail. And a good example of that are the audit reports, the serious incident reports, and you can see they're mentioned in the escalation reports. But because we have concerns, we are keeping them on them, we keep revisiting it, and we are holding people to account. We keep asking what's happening on all of these things. So there's the history is not forgotten. We keep looking at that and making sure that that is tied up and crossed off. So I think from my perspective, if this is an assurance perspective, the committee seems to be really scrutinising quite closely. And I think I would echo what Terry has said. You know, things are not forgotten. There is complete follow-up. And the links between the IPR, the audits, the serious incidents, and then the specific areas that you see in those escalation reports are followed up quite thoroughly. That helps.
And just as well to complete that, Marcia, in the many informal exchanges I have with the chief executive, usually the first question I ask, particularly after a busy weekend, is what's the weekend been like, and have we had any incidents? Because it's obviously very mindful that the probability of something going wrong increases with however busy we are. So it's something we're monitoring formally and informally as well, very mindful of that. But we're also mindful of the pressure that's on the front line. Well, all of our staff. It's not just the frontline crews and people in EOC, but this affects the people as well who support them, particularly in the kind of work that you do, Marcy, and others. There's also an increased workload throughout the organisation as well. It's a consequence. Okay, so anything else on that particular committee's work?
David, may I just say something about the pads, the defibrillators that
please, yes, you may, sorry.
I think this is a really good question for the governors to raise. Within walking distance of where I am now, there are 3 public access defibrillators. One supplied, I think, by CCAM, one supplied by the parish council when they had money left at the end of the year, and the other bought by pub regulars. those 3 defibrillators have all got different management systems around them, and they may well all be on our system at Crawley, but actually different companies manage them, and I think we manage one of them. There are sorry, a dog has just appeared in my office. There are literally thousands of pads across the patch. If you go to your nearest public access defibrillator, you will see that it might be managed by any one of a number of different organisations. It might have been provided by any one of a different number of organisations. And the thing in the minutes that I think is most significant is that if someone goes to a public access defibrillator and it is not working, the first people they will hold to account for that will be CCAM, even if we don't know about it. So the challenge with public access defibrillators is, one, to make sure they're all working when people want to use them. Second, that everyone is owned and maintained by somebody. And third, that when new ones are purchased, and I suspect there'll be another cluster coming online soon because of unspent parish council funds at the end of last year, and many parish councils will buy public access defibrillators. There's barely a phone box in West Sussex that hasn't got either a library inside it or a defibrillator. There isn't one with a phone in, but they're pretty good on defibrillators and books. And I think the public assumes that they're ours. So the particular challenge that I think has been identified is that there needs to be some sort of coordinated approach to managing these, both in terms of public safety, because people do have a right to expect they work, but there's also the issue of reputational risk to CCAM if they're not managed. And bluntly, I don't think we have the resources to manage them all. I think when people buy things like defibrillators as a gift to the community, they often don't think about the management costs. So there are lots of issues about public access defibrillators that end up at our door, even though we're not responsible for them. But reputationally, we are. So I think there's a very good piece of work being done in the organisation about this. But I think governors need to be aware that it is a significant risk to the organisation, because people will assume it's our fault if they're not working. And for governors, there is a particular thing that I think you could help with, and members generally, because so many of you are active in the community in other ways. It is about ensuring that every time there is a community project around a defibrillator, to make sure that it is properly owned, properly managed, properly serviced, and that we know about it, and the British Heart Foundation know about it. So it's well spotted, Marcia, and I think it is a significant risk to the organisation, because an awful lot of those defibs out there aren't our responsibility, but people will assume that they are.
Yeah, but thank you for clarifying that, Terry. It's appreciated that. And I think, Philip, can I be clear? This is it on the executive workload, isn't it? To be clear, what is CCAM's responsibility here, and to be absolutely clear, and we'll take that responsibility. We'll also be clear what is not. It's not for us to maintain and support.
Yeah, no, that's right. So there's a known number that we're responsible for. We're very clear on what that number is, and we are at the moment we've got a group of staff who are on alternative duties, who are using their working part of their working day to go around and do that checking. And making and fixing the bits that aren't fixed, but we are discovering a lot of in that process, a lot of the ones that we're not responsible for, that either aren't there, even though they're on our CAD. They used to be there, but they've been removed because there's been a change of ownership or a change of management or something like that, or don't work. And so we're trying to get those fixed at the same time. But we will absolutely have ours working and running, and we will do what we can with the rest of them, but we can't be responsible for the totality.
So the action is with the executive, but the QPS will be working with the executive to make sure that we, and particularly we will obviously report back to the council, and we would, to echo Terry's point, we do need feedback from members and governors here. It's going to go two ways, because we need to be clear what we can do and what we can't do with the public, and actually it's almost reputational risk, is that we're seen to be washing our hands of certain defibrillators when they're not our responsibility. So we need to manage it carefully. So there's a need for some careful communications here, which we will certainly manage with the executive team. Now I've got further questions from Harvey and then Howard Goodborn. So Harvey.
Yeah, this is it relates to page 7 of the integrated performance report and the time to answer 999 calls. The mean target is 5 seconds and the 90th percentile is 10 seconds, which is, from a statistical point of view, absolutely right, because normally the 90th percentile is higher than the mean. But we're quoting now that we're achieving 5 seconds as a mean, and yet the 90th percentile is just 2 seconds. What that means mathematically is that 10% of our clientele are on average having to wait at least 32 seconds. Now, either that statistic is wrong, which I hope it is, or we're really letting down some people, and that really goes to the heart of quality and care. I've raised something similar to this on previous stats, and somebody was going to look at it, but I haven't heard an answer. So I'd like somebody to look at this, because it statistically it just shouldn't be that you've got a 90 centile which is under the mean. You're talking about positive numbers.
Yep. Thank you for that diligence, Harvey. I can't answer that. I'm not sure that other committee members can at the moment, but whether our chief executive can give you a response initially, but we do need to go and look at this in more detail.
I would like somebody to look at it. It may be true, but I can't think of the reason.
Harvey, when I first arrived, and we were doing 2 seconds. No, sorry, it was just after I arrived. We were doing 2 seconds average mean and 1 second 90th. I queried it, and I was given a very, very solid explanation of why that was possible and right, and I can't remember what it was. that I'm afraid is the benefit of my senior years.
We'll get it.
I remember being reassured that, and I haven't asked the question again. But I will go and ask it, and I'll get you an answer.
Thank you very much.
Thank you. Sorry, I got my Howards mixed up. Howard Prescott.
Hi there, that's okay. Thanks, David. Just a reflection as well. So looking in the IPR document, it talks on page 15 about the risk register, and that 52 to 59% of risks at the moment are not in date. And I suppose a question which is about how assured do the NEDs feel about the management of the risk register. I can see that there are actions which are outlined in the IPR, but then when you're looking at the papers for, say, for instance, QPS or from the audit, there's no mention in terms of risks that score 12 and above. So I just was wondering how assured the NEDs feel about the management of the risk register at the moment.
Thank you. Michael, Michael Whitehouse, Chair of the Audit Committee, can I ask?
Chair, if you can hear me. So thank you, Howard. It's a very good question, and it was raised at the last meeting of the board, which took place a week ago. We were given assurances around the risk register, and can I take your question in 2 parts? First and foremost, the Director of Nursing, who has got responsibility as an executive for the integration of the risk register, gave us assurance that because of COVID and other pressures on the trust, some of the risks had not gone through the formal process of being updated. But in terms of the bigger strategic risks that we felt that impacted on patient safety, financial performance, were being reviewed appropriately and were considered at the last audit committee. So what I would say to you is it doesn't look particularly brilliant on paper, but we did actually seek that assurance, and they are being updated. But the big risks, the big ticket risks, are certainly given sufficient, what I would regard as chair of the audit committee, considerable scrutiny at board level and throughout the organisation. But it's a good point that you raised.
Thank you.
You content with that, Howard? Yep.
Yeah, no, that's fine. Thank you.
Good question. Thank you. Anything else on the quality and patient safety before we move on? Minutes. Sorry, Nikki, I do apologise. Nick, then Jeff.
Well, no worries. I was just going to circle back to Marcia's point on the AEDs. As a CFR scheme in East Sussex, what we do is we go and find all the AEDs in our patch, and then we basically upload them to the CAD, and so CCAM are aware of them, and we will go around and look at them and maintain them, and then just feed that information back to whoever's leading in CCAM in that particular area. So this could be a really good utilisation of CFR schemes to look after pad sites in their areas, as not to stretch people who are doing it on their day-to-day work. They can just be fed the information from the schemes that are currently already looking after pad sites that they've put in. Yeah,
thanks, Nikki. That's a really good point, actually. We'll note that and make sure, because the community resilience team are central to this process anyway, reviewing these access to defibrillators. So we'll certainly make that point. Thank you. I think that will be a really positive step, actually. Okay. And so who was next?
Sorry, can I just add in quickly there? It's Vanessa here. I'm sorry. If I put my camera on, I'm likely to lose you all. So, but I've actually got a defib that we're looking after at AGK Thanet in the middle of Margate seafront. So it would be really good to be looped in there as well. We managed to get it donated through CCAM, but we've taken the maintenance over. So that would be really good to have any support as well. So if there's anything in Kent, I would really appreciate someone keeping me in the loop.
Thank you. Thanks. That's a really important site. I mean, particularly with staycations, Margate has never been busier. So that's a very good point you made.
Well, we really fundraised for it because someone passed away in a shop with a heart attack. And if there'd been a defib nearby, I'm sure they would have survived. So I've been working really well with CCAM to make sure that we have got them in the right places. So yeah, it's really, really important. But like you say, it's really, really important to the maintenance, to the point where I've just emailed my team just to make sure that we are maintaining it properly.
Thank you. Thank you. I think Vanessa, you wanted to come in with a question.
That was Vanessa.
That was Vanessa. Sorry, there's one other. Jeff. Sorry, Jeff.
Yes. Sorry. No, actually, I was.
Get my notes mixed up. And when people remind me there's questions, I get several messages. So, Jeff.
That's all right. Nikki, to some extent, highlighted what I was going to say as well, which is we have local CFRs on the ground who are, most of them are probably aware of their local pad sites, but I think it would be useful if we could actually get an extract of the CCAM database of pad sites out to local CFR groups, so they can double check that those pad sites still exist and that they are being maintained.
Yeah, good point. And certainly make sure the QPS is made aware of all these comments, and we'll ensure from QPS that there is a systematic process put in place to review the defibrillators and what's CCAM and where our CFR team can help maintain, support them in future. So that I'm sure we can do a lot more than we are currently. So thank you for that. Lee, did you have a further question?
No, it's just without dragging it on a bit, the AED point. I spoke to one of the people Philip mentioned that's working on this project, and they're trying to give the team leaders access to Power BI, which has got the database on it, and to allow the CFR schemes to update directly into that.
And is that access being made available? There's no impediment to that?
It's still, I think IT is still trying to work out how to do it, just so that obviously they're protecting the access and controlling the access.
Okay, well, that's noted, and ask Isabel to make a note of that, and we'll chase that for you to make sure that there may be some appropriate bureaucratic impediments, but so we need to check just to make sure. Okay, thank you. can we move on from the Quality and Patient Safety Committee? Thank you. Ask you to note those 3 sets of minutes which are before you, and hopefully you take some assurance to the range of subjects that are being covered, both in normal business but also in terms of maintaining good safe systems during the pandemic. Moving on to the Finance and Investment Committee, we've got 2 sets of minutes which are there. Just to check, I think Howard Goodburn is not able to be with us this morning. That's correct. Howard had previous engagements, but there are other members of the Finance Committee here. So if there are any questions from the governors regarding the work of the Finance and Investment Committee, we'll do our very best to answer them. I can't see any hands raised, so are you happy to accept those? Oh, so Marcia?
Just a quick question, really. On, I think it was page 32 on the IPR report, there was the response performance. So it was comparing our response with the other ambulance services. And I think it was West Midlands was all green and South Central and London ambulance service, if I'm correct. They're also doing pretty well. I'm just wondering, you know, is there anything that they're doing that we should be doing? Is there anything that we can learn from them? That's all. Really.
Good point. One that we consistently ask as non-executives. Michael, do you want to comment on that? You're on mute at the moment, Michael.
Apologise again. Marcia, it's a really good question, and it's a question that I made. I think every NED who joins the CCAM board raises this question, because when you look at West Midlands, it consistently seems to perform better. I think, without getting into undue jargon, I think this gets to the heart of the fundamental strategic question about what CCAM is seeking to do. You know, whether it is an ambulance service that just transports people from one environment to another, you know, from home to hospital or wherever, or whether it is trying to provide a much more sophisticated, what I would regard as a more forward-looking model of care, which is basically a targeted dispatch model that you try and treat people in the most appropriate setting for their condition. And that means why you will have situations like hear and treat, see and treat. And I think personally, looking at the NHS more widely, that is probably the best way forward, because if managed effectively, it reduces the loading on the acute sector. And I think communities as a whole get a better service. What that does mean, however, it is a more complex model to manage and to sustain. And I think where we are in the evolution of that model is we need to have a fundamental review of it, to look at it in comparison with other foundation trusts operating in the emergency services sector and 111 sector, and to see what wider lessons that we could learn. And that is the review that David Hammond and Emma are leading at the moment, which is to look at our operating model, to look at how we deliver care. But I think as a board, and I hope I speak for my colleagues, I think we genuinely feel that the way CCAM is seeking to respond to patients and those who look to us for support in multiple ways that best meets their needs is probably the best way forward if we are going to continue to be a responsible member of the health community within the South East. I'm not a clinician, and I may have probably not explained that as well as I could, but I see that Philip has got his hand up as well. So I'm sure Philip, as Chief Executive, will now correct me. But there you are, Philip. Over to you.
Philip, do you want to comment?
Do I want to correct Michael? No. No, I know that what hire and fire means, and so no, I won't be correcting Michael. I was going to make a slightly different point. I was going to say to Marcia that yes, it's a really good question. It always stands out, and they're different. The 3 trusts that have done it are more successful at meeting the time-based targets than us for different reasons, actually. So West Midlands have a massive conurbation where the vast majority of their patients are urban. So do London. In the urban environment, so where we have urban environments, places like Brighton and that, we hit our targets really quite easily. Where it's rural, it's much more difficult. So there is a difference there. But West Midlands, what West Midlands have done over many years somehow is persuade people to pay them a lot, and therefore they can have far more crews out and about. So they've been really successful over that, and it's over many years. And we've only just in the last few years persuaded the local health systems to up our funding as a trust, and we're still building that towards what we think we need. They have a much simpler system. SCAS are probably closer to us in terms of the geography and everything else than those other two trusts. So we have more to learn from SCAS, South Central Ambulance Service, and we are doing that. We are. So we are just about to bring in a whole bunch of systems in the centre which will allow us to plan our operations much more precisely, which we have basically copied off SCAS. So they've been really generous with their time and expertise, and these are the systems that they've bought. These are the way they do their planning. This is how they predict their performance and therefore make decisions and change the decisions. So that's all of that we're taking off them. It took them. So I started doing that in SCAS 5 years ago, and it's taken 5 years for it to work. Well, we think by stealing it off them. And using the lessons that they've learned about what works and what doesn't, that we'll be able to get it running well in 2 years. We've been doing that work for about 6 months, so it's not here yet, but it will make a difference, and we will continue to learn from anybody who's doing something well. Most of the ambulances trusts do something better than all the others.
If I may, but just to add to that, Marcy, you ask a really good question. It goes really to the heart of the work of the board, is because how do we perform appropriately and meet the demand from our patients and do it consistently, and be an organisation that Philip was talking about there that's proactive rather than reactive. It's in our DNA to react, but there's so much things that we do, we can plan more effectively and do with a certain degree of foresight rather than just reacting to all that we see. So to be clear, as a board, we do have a clear strategy which the whole board owns, and we hold the executive to account for delivery of our strategic direction. But more importantly, we are looking in great detail at how we are working and organising. That's going to pose some difficult, challenging questions, and that's reflected in my personal objectives as well for the year ahead, as well as the work of our various committees to ensure this organisation gives a good account for itself in the wider health service and to the public. And that's not decrying of the great work that we do, but we need to be able to make sure we can explain, because it's these comparisons can be used against us sometimes, and we need to make sure we can answer those constructively as well going into the future. I think Laurie, you wanted to come in with a point?
Yeah, I just wanted to build on what you just said, and also on Michael's point about the difference between the operating model we have in terms of targeted dispatch and what some of the other ambulance trusts are doing. And I think actually in developing that approach in CCAM and in the strategic direction that we've taken over the past year or two, my feeling as a board member is that CCAM is ahead of the game. Because if you look at the policy shifts in the NHS, which have been a long time coming, but are going to be embodied in the white paper, it probably means that other ambulance trusts are going to be asked to do something much more similar to that which we're, to the kind of service models that we're operating. So this is to do with place-based care, with an accent on local partnerships of providers, taking a lot more, having more autonomy about how they run emergency and urgent care pathways, the shift to population health, and the whole emphasis really on communities rather than just with patients. And I think you'll see as that becomes more evident in what our commissioners and customers are asking, the kind of experience we've got and the way we're set up to do it will actually match those new requirements. And I think we may find that some of the trusts that operate a simpler model may find they've some catching up to do.
Yeah, thank you. Right, I think I can't see any more hands raised for that Finance and Investment Committee, but I think in summary, the finance of the Trust remains as predicted. The Finance Committee under Howard are very diligent in making sure that we are delivering on our promises, and that's been one of our key pillars of success going forward, is we deliver what we promise, not just in terms of performance or performance for patients, but also our financial performance, because it's always used as a key indicator within the NHS that you meet your promises. If you can't meet your promises, you have a good explanation for doing so. So that's the non-executives are very well early on to that to make sure we do. That's the case. Now, moving on to the Audit Committee, we've got 2 sets of minutes of the 11th of March and the 20th of May to receive. Michael, as chair of the Audit Committee, is there anything you wish to bring it to the attention of the Council regarding the work of the Audit Committee?
Yeah, if I may, Chair, there are 3 points that I would make. I would take the reports as read, but there are what I would call 3 general points that, in terms of good governance, I should emphasise to the Council. The first relates to where we are in the business cycle. So we completed financial year 2021. The Audit Committee over the last 2 meetings has been focusing very much on supporting the executive and holding to account to ensure that the Trust has appropriately audited financial statements and an annual report that it can publish and submit to the regulator to discharge its responsibilities. So last week, the board formally took the Trust's financial statements and annual report, not fully approved yet, because we have a final meeting of the Audit Committee on Monday where we'll be talking to the external auditors to give final recommendation to the board to approve the accounts and annual report. But the results, subject to final audit, look very good. We've broadly broken even. That's our expenditure is matched by our income. There are some oddities that we have to make some accounting adjustments to reflect the amortization of assets, which increases the deficit. But in terms of cash terms, it's a fairly good result. And the reason why I say that is we've alluded to the uncertainty that exists at the moment in terms of NHS finances. I think that reflects more widely what's going on in public finance until the Treasury agrees the next expenditure round in the autumn. But given the environment in which CCAM has operated, uncertainty about funding, money coming in to support COVID, I think this is a good result. The other thing I would stress is not many people read accounts, I know, but to have a clear audit opinion is very important in terms of what it says about the financial stewardship of the organisation and the way it's run. So fingers crossed, we have no reason to believe that the external auditors are giving us anything other than a clear opinion, and that will be concluded on Monday. You may be aware as well that the public sector is different, the NHS. Our external auditors are also required to give a value for money opinion on us, and this is, have we used our resources in the best possible way to represent taxpayers' interests, to deliver cost effectiveness and ensuring high quality of patient care. The audit opinion, the nature of the work that the external auditors do has changed. The external audit opinion has become more demanding. It focuses on a number of aspects of the Trust's performance. And again, we were given an indication that we will get a positive result from our external auditors, and this will be confirmed on Monday. So first and foremost, I would say to council members, this is a good result for the Trust, and I would pay tribute to Philip and David Hammond and their team in terms of ensuring that we have got to this position and have met our statutory requirements. So that's a good result. My second point, if you'll bear with me, is I think we need to recognise that the financial statements are really a summation. They depend on a number of factors, a number of key aspects of performance that the trust needs to demonstrate if it is to get a clear opinion from the external auditors. And again, it's worthwhile just reflecting on those. So the first is we need to give assurance that we are managing the risk of fraud and malpractice in the way in which public money is utilised by the trust. We rely on independent assurance by our internal auditors. Again, happy to report that the Audit Committee received positive assurance, and we are also benchmarked against other trusts in terms of the controls and procedures that we have in place, and we came out fairly well in terms of that. We also have to be confident that we hold patient information, we hold information on a range of different aspects related to the work that we do. You may be aware that in the public media there is a lot of concern now about protection of information, and we have to have in place a very strong control environment to ensure that we protect information, and the accounting officer, that's Philip, has to give assurance that that is all well controlled and maintained. And again, we got assurance from our internal auditors that that was the case. And then the final element is what I call how the business, if I can call it that, the Foundation Trusts manages its activities. And throughout the year, we take a range of reports from internal audit that are done independently. You know, internal audit are not directly employed by the trust, and they have to comply with their own professional standards. And every year they give an opinion on whether our governance is good and would hold up to external scrutiny. I'm pleased to report that again our internal auditor awarded us a moderate assurance, and that is probably as best as we're going to get at the moment. That shows that our systems are working appropriately and that we have a good culture of compliance and consideration for making sure that public money is used effectively. I've gone into a little bit of detail, but it is important as council that you understand and get that assurances from me as chair of the Audit Committee. My third point, rather than focusing on individual reports, what I'm particularly interested in the chairmanship that I provide to the committee, the Audit Committee, is that we bring out systemic issues. And what I mean by systemic issues is if we're confident that those systemic issues are managed and are improving, we can be confident that the trust is continuing on its journey to be a well-performing trust that manages its resources effectively and delivers high standards of patient care. I think there are two issues that I would highlight that came out from our work. One is, I think there is still more to be done on what I call the supply side. That is very much around ensuring that we have appropriate skills coming into the organisation that are sustained, and that relates to not just recruitment, it relates to staff wellbeing, what Philip focused on earlier, and it focused very much on ensuring that we have the right skills and resources to maintain the high standards of care. And it's the point really that Marcia made earlier around patient safety. I think CCAM is still on the journey in that space. We recognise that we've got more to do, but what I would emphasise to Council is there is a lot of work in play that the Audit Committee will continue to monitor. And I know Laurie, a valued colleague who chairs the Workforce Committee, is looking into this, and we will continue to see improvements over the next 12 months. And that's very much why we support the review that David Hammond is leading with Emma on looking at our operating model and ensuring that everything is aligned to ensure that that delivers the best that we can for the CCAM community. The second point I'd say is it's around not just responding to immediate problems, but taking a longer term perspective to ensure that you anticipate problems and that you have got strong resilience to be confident that you can deal with anything that comes out of the blue. I think CCAM has an incredible track record at responding to initiatives, to problems as they arrived. COVID is a really good example. What we as a board and the Audit Committee are encouraging the executive is to focus much more on longer term issues. And that again relates to the work that David Hammond and Emma and Philip are doing about looking at our longer term operating model and how we ensure that that is resilient. I apologise, that's quite a long spiel by me, but I wanted to give Council assurance around the direction of travel and the governance and the way in which the board is seeking to support CCAM in its journey to continue to provide excellent patient care. Thank you.
No, I think it's very important, particularly this time of year when we're closing down one set of accounts, receiving appropriate sign-off from those that review our work and planning for a new year, which already has started, but nevertheless, we are still in planning phase for a number of issues, particularly how we're going to emerge out of the COVID pandemic and get back to some semblance of normal business. So, colleagues, any questions of Michael and members of the Audit Committee? You can take some assurance that we are appropriately well governed. Okay, I can't see any hands raised, so then we'll move on then to the with one thanks to Michael. Thank you, Michael, for that excellent report. Move on now to the scrutiny item, where this is when we look in depth at the work of one of the board committees, and today it's the Workforce and Wellbeing Committee. And Laurie, as chair of that committee, is going to be our guide through that work. So, Laurie.
Thank you very much, David. As you'll see, there's a set of slides in the pack which detail when we met and the kind of issues that we've covered. I don't really think there's much point in taking time to go through these in detail. What I'd like to do more is to concentrate on the areas with which we focused, and following on from Michael's point, some of the challenges that we can anticipate coming out over the horizon. Since this is the People Committee, I suppose I ought to start with people and to talk about changes in our membership. We lost Al Reimer, who retired as a NED and therefore from the committee, and I think we need to say a big thank you to him. His commitment to the committee was phenomenal, and his terrier-like attention to detail was really, really useful. As I think, David, you've already mentioned, we're soon to lose Terry from our NED complement and from the WWC. That's a great loss. Terry's I can't see him blushing, but Terry's understanding of the dynamics of CCAM and the small p operating environment in which it works was unbelievably useful, and especially his encyclopedic knowledge of the further and higher education system. So we will really miss that expertise, I think, and have to make that's the goodbyes. The hellos are to Tom Quinn, who can't be with us today. He's on holiday. He's a senior academic at St George's, a clinician. He's a fellow of both the Royal College of Nursing and the College of Paramedics, and there's not much about clinical education that he doesn't know, and as you'll see in what I'm going to say later on, that's going to be really quite important to us. Tom has also taken on the role of Wellbeing Guardian for CCAM. Actually, it's for the NHSE. It's something that they've asked us to do, and I'll speak a bit more about that later. And also, who's with us today is Subhoshan Muganathan, a clinician, but who spent most of her career in education, training, and transformational change roles in the charitable and public sector. An experience with which I know we're going to draw on quite a lot. So two great assets to WWC. Welcome. We're going to exploit you a lot. And can I just say thank you to the governors for excellent appointments. I'm really very happy with what you managed to supply the WWC with. That's your NEDs, but I think equally important in this deep dive, changes amongst the HR executive and management. You'll know about the Ali Mohammed, our Director of HR. He has now gone on to recruit Porter as Deputy Director of HR, Lucy Wild-White as Head of Workforce, and most recently Yvette Brown of Learning and OD. And this is a significant change. Since I've been in CCAM, I've always felt, partly because of our reliance on interim people, partly because we just didn't have the capacity, that in a sense the HR department was not able to handle the kind of issues that were on the agenda and are going to be coming up. So what I'd say is, for the first time in my time at CCAM, we have an HR team with the capacity and capability to handle the really tough workforce and well-being issues that we're going to have to resolve. More of that anon. So if you look at the work of the WWC over the past year, the obvious change I'd draw your attention to is the way in which problems with basic HR processes have been handled. Things like electronic timesheets, about personal files, about expenses and driving licenses, things which seem fairly mechanistic, but if you get them wrong, cause great friction between line managers and staff. And I think here the committee has sensed tremendous progress being made. I mean, just as an example, a year ago there were thousands, I think literally thousands, of personnel files who weren't on the system. Now we're down to just a handful. And this has meant that what used to be on the agenda as HR improvements now figures as HR performance. It's moved to business as usual. I think we're really getting on top of that in a way we never had, never had before. And I think it's interesting that even when we record a risk as partly assured, there's an undercurrent within the committee that we're confident that the HR team have the capacity to resolve it. So it may still be a risk, but it's not something which looks out as if it's out of control. The other remark I'd make is a bit of a softer comment, and that is the sense that HR are working in a much more integrated way with line managers. So what you're seeing is some of the problems, I'll talk about clinical education in more detail later, but some of the problems being resolved with high levels of engagement with line managers. And also there's some evidence that the way they're working on the staff side, with staff involvement and with the staff side organisations, is much more integrated, much more constructive. And I'd be interested to hear from the staff side governors if they've sensed that difference in emphasis, that difference in the way that they've engaged. This shifting of the HR processes to business as usual has probably enabled us to make a number of shifts in the balance of the work of the WWC. When I joined CCAM, the emphasis was all on scrutiny. It was about looking backwards at how, indeed if, we had performed, how we had done things. And now with much more of the process stuff, as I've said, being better managed, really echoing what Michael has said, we're able to look forward at some of the bigger risks coming over the horizon for WWC. And that, I think, if you look at the agenda and the agenda in the futures, you already can see some of those meatier, if I say softer, people think that means easier. I don't. Meatier issues appearing on our agenda. I'll deal with some of those in a minute, but I wanted to say something about an issue that's been with us for quite a while, and that's the clinical education function. You'll know we've had two, I don't know whether I should mince my words or just say failures in relation to our clinical training schemes, both the AAP and the ECSW, I beg your pardon, that have been identified by the WWC. And I think we should give full marks to the clinical education team for putting things right. They went wrong, but they really worked hard to put things right. what they call their rectification projects, I think have been an exemplary recovery process, both in terms of work with providers of education regulators, worrying about staff welfare, and also worrying about the effects of a failure to train clinicians on our establishment and therefore deliver targets. And I emphasise in that it's interesting to see how much they focused on the well-being of the learners who are affected by the problems within those schemes in clinical education. I suppose it's becoming clear, though, that there is a lot to do. In the last set of minutes you will have seen the newly appointed consultant paramedic in charge of clinical education and training, Ashley Richardson, made clear about the workload and the issues that have to be resolved by him and the team in the future. And I think you'll see that the committee expressed confidence in his ability to harness the team, to work with managers and with staff, with regulators, outside suppliers, the whole of the field, to get things working properly. So there's still stuff to do, but we're confident, I think, that the executive are aware of those issues and are in a place where they can be resolved. There's one thing I wouldn't mind bringing up, and Terry, I just wondered if you'd like to talk about this, that in the minutes you'll see a report from an independent audit undertaken of the clinical education function. And this contained a worrying detail about the work of Crawley College, who've been very significant, we thought, in helping our recovery of the programmes and getting some order into them and making sure what we were doing was acceptable to regulators. But their work did not seem appreciated in the survey of staff. I just wondered, Terry, if you'd like to comment on that.
Yeah, thanks, Laurie. Chichester College, Crawley College is part of the Chichester College Group, which is, I think, one of 4 or 5 outstanding college groups in England. So it is in the top 5, certainly, and may even be in the top 1 or 2. And colleagues may also be aware, I think, that their principal has just been headhunted by government to lead up the Further Education Council. So it's very well considered, very well regarded. So we approach them to support our development in terms of clinical education. And there are always going to be difficulties, I think, when you move from an in-house service to effectively an externalised service. And Ash, as Laurie intimated, the new head of clinical education, has undertaken to review why the figures relating to Crawley College appear so poor on the surface. But one of the things we also know is, if you go back a year, some governors will recall when the audit was done on teaching and learning within clinical education, swathes of work was unmarked. There was poor feedback to students. We identified tens of students that were not likely to finish their courses because they hadn't been regularly supported and monitored. So I think there's been a sea change really in expectations in terms of clinical education and in terms of students. And it's really important that the organisation gets to the bottom of whether the issue is actually an issue with Crawley College or an issue with raised expectations across the system. It's difficult to understand how Ofsted could go into a college and find it outstanding, and yet our staff find very significant issues with it. And just to give you an example, when we did a bit more review of the data, it turned out that we were asking all of our staff about Crawley College, including very significant numbers that were not attending Crawley College. So how they could have an opinion on it defeated us, really. So we asked colleagues to drill down a bit further into the data, and still those attending Crawley College found some issues with the teaching and learning processes that they were being taken through. So there's clearly an issue there, but what the issue is, I think we've had to say we just don't know yet. But I think what we're seeing is the increased professionalisation of clinical learning. We've never had a doubt about the clinical expertise of the people doing the clinical learning. I think we've got significant evidence that historically some of the teaching and learning skills were perhaps not what we would want. And that was, I think, what Ofsted picked up when they came to look at us. And they'll be back to look at us again. So it's important we get to the bottom of this for two reasons. Firstly, if our learners feel that they're not getting a good deal, we need to address that. And if it turns out that our contract with an external provider is not delivering what we would expect, then of course we take that back to them as the contract provider and ask them to sort it out. So that's the processes we're going through. And I would imagine, Laurie, that I don't want to place a commitment on you with me leaving after this meeting, but it may well be the sort of thing that governors might want a feedback on at a future meeting, because it does concern so many of our staff, I think.
Thank you, Terry. And I think without any doubt, it's going to be a major focus, continuing focus of the WWC, in part because it affects the establishment of clinicians to get out there and help us meet the needs of patients and communities, as well as the well-being of the staff themselves. So you'll see that on the agenda and appearing in the minutes as we pursue that. It raises an issue also.
Laurie, sorry if I may, David, through you. I can see Waz has got his hand up on my screen.
Yeah, was that a point related to education?
Yes, I do. Thank you, Terry. I was just going to say, I'm really put it on Laurie's radar. I've had a few very strong complaints about Crawley College being pushed in my direction, and I understand they've now been formalised into official grievances. So I just really wanted to make sure that it was on your radar, that maybe that would help triangulate your views on what's going on.
Okay, thank you very much, Wasim. I think that will be part of. We need to make sure that's part of our ongoing review of that particular issue. The audit was actually quite favourable in general, apart from this really negative aspect of opinions about Crawley College. I'm not quite sure how those grievances come to light within WWC, but we'll make sure they're included in the intelligence we gather about the work of Crawley College. So thank you for that. Okay. Well, in a sense, the first issue I wanted to big issue, which I think is on the agenda, it sort of follows on from that, because as Terry has said, the problems with clinical education weren't to do with the clinical side of things, they were to do with the management of education. And this raises an issue that's occurred a couple of times in commentary within WWC about the whole of the education and training function within CCAM, how it's managed and where the accountabilities and responsibilities lie. And I think that's something probably we're going to look at in more detail, just to make sure we're doing the very best that we can. The other issue which I think is important is to note the pressure on, which has come up a couple of times in WWC and also in NED meetings elsewhere, is about the nature and the pressure on our establishments. If we're going to meet our service requirements by putting people out on the road, whilst fulfilling requirements for education and training and other HR functions like appraisal, there's a suspicion that maybe the establishments as they are unsustainable in the longer term. And so this is going to be something I think we're going to look at in more detail, just to make sure that in terms of delivering performance in the short term, we're not jeopardising our ability to staff our services with properly trained people in the longer term. A shift I think is really worth mentioning, and in some senses Philip presaged this earlier, is when Tom Quinn first joined the WWC, he said almost in an offhand way that it's interesting, if you look at the agenda, there's a lot to do with workforce and not much to do with well-being. And in the committee there was a sort of silence when he said it, because it was evidently true. And I think what the WWC, having accepted that, are really determined to do something about it. One part of that, which again Philip has already talked about, is we're currently searching for proper indicators so we can routinely get the performance of the organisation in terms of staff wellbeing reported to WWC and then through us to the board. And it's interesting, we're not just interested in how CCAM as a whole organisation is doing, but we're looking for the hotspots, because if there are within corporate functions or operating units in the field places that might require special attention and support, I think in WWC we need to make sure that that support is forthcoming. Relating to wellbeing, Tom has been appointed, as I said earlier, as CCAM's wellbeing guardian. This is a scheme. It's an NHSE requirement, which means we have to comply. But when Tom explained what the NHSE expectation is, we agreed that nothing really was in there that we would take issue with. So conforming to it will be relatively easy, and we're hoping that satisfying the NHSE requirements will be just part of what we do naturally. But it will give both NEDs and governors extra assurance that we're looking after our staff as well as we possibly can. Workforce planning has been mentioned already, and I think that's becoming of greater interest about the nature of workforce planning and what it encompasses, because I think we're shifting from simply recruiting and trying to recruit and retain staff to meet the establishments that are required currently, we've agreed currently with commissioners, to looking at future demand and responding to changes in the operating model that may be required in the longer term. And as Michael suggested, this fits with closely with the work of the Better by Design grouping, which are trying to see what operating models might be appropriate in the future. So that I think we're going to spend a lot more time on, making sure that we have something that is sophisticated enough to meet the future demands on our services. Coming up, I think also is an OD issue. OD, organisational development, fits within the terms of reference of WWC, and this is often referred to as matrix management. This is really continuing the work that Joe Garcia began in developing management devolving management responsibility to line managers, beginning to shift away from tendency to top-down approaches and creating more autonomy at a local level. The phrase freedom within a frame is often used to kind of typify that approach. And I think what's important is that it is a much more agile way of working and a much more agile way of managing, which is going to be important given that we're operating in a relatively turbulent environment. And as I said earlier, it responds to the white paper changes as we shift to towards place-based. Is that place-based services? So strengthening the autonomy and capability of local OUMs to engage with local providers seems quite important as they manage and develop our care pathways. It's a big organisational development issue, both for those managers and for the corporate functions actually being able to support them. Another change I've welcomed is the presence of governors at our WWC meetings as observers. And we've had governors observing our meetings. The NEDs will meet with you before and after meetings to discuss the agenda and the outcomes. And if you'd like to get more involved in that, we would really welcome that engagement. I think that's a very positive move. And to follow on from Nikki's earlier remark about being allowed out, I think the WWC are also going to need to talk about how we best get out there and engage with people on the front line, not just in green, but also in the corporate functions, to get a feel for how things are going on out there, how they feel about things, and to identify issues which should be of concern to us. So I think that opening out is something we really are going to put on our agenda. So in terms of key responsibilities, I think what we've got is a much more future focused, looking at future risks, we're shifting much more into the well-being side of our terms of reference and more concerned with larger scale organisational development that we have been. In terms of risk, I think I've identified some of those, but in terms of future plans, I think I've outlined some of the things that we're going to be doing in the future. Thank you very much indeed, Chairman.
Thank you, Laurie. Very comprehensive. That's a very good excursion through significant work that's been undertaken by the Workforce Committee to ensure that our workforce is appropriately led and supported. So, colleagues, before we take questions, just to clarify, there's some very helpful notes in the comments section from Peter and Terry, just setting context regarding the Crawley College issue. So that will just help people frame their understanding a little bit more of the survey that we had of staff. Colleagues, any council, any questions and comments of Terry, please, of Laurie and members of the Workforce Committee? I've got one. Sean, can I see? Sean?
Thank you. Laurie, you touched on what I was keen to address in terms of the well-being of learners. In the last minutes, it was noted that students who worked full-time struggled with pastoral support and structures to support students in their learning. I'm glad to hear that the WWC has assurance around this now Ashley is in place and that this is being progressed for more than just a consideration.
Yeah, I think it's very important, and I think you can see a lot of the effort that the clinical education team has been to ensure that, in a sense, our mistakes don't disadvantage the staff more than they have to. It really has been quite a difference in feel, I think, in making sure that our learners are being looked after. So, thank you.
Just on that, what my impression is though as well, Laurie, I mean, maybe Waz can confirm or deny this, but all of our qualified staff do take very seriously their responsibility towards learners and in the organisation, and I think there's an awful lot of informal pastoral support that happens that doesn't get recognised necessarily by formal processes, but that's something which our staff take very seriously in terms of particularly the older hands, as it were, guiding young entrants.
Absolutely.
Yeah,
sorry.
Do you want to comment on that? Are my impressions correct or not?
Yes. Sorry. Yeah, correct. Also, all paramedics do placement to help learners, and that has actually been rolled out to ECSWs, technicians, as well as paramedics. So there is a lot of support in place for students.
Yeah, I think one of the things that came through was seen in some of the early work of WWC was the lack of support that line managers had to support their learners. That, in other words, they were left as line managers with nothing really, not very much anyway, coming from clinical education to help them with the help learners achieve their targets. And that's something I think which looks as if it's changed. We'll follow it up. But I think that has been it is certainly part of the intention of the clinical education team to make sure line managers are supported much better in how they look after learners in their care.
But I hope the council can take some assurance that certainly in the work plan for 2021-22, the matters of education are a concern for the whole board, not just the Workforce Committee, and it's something which we do want to see the present rate of improvement continued, because it's important. It's a key subject. It's key to our values. It's key to what we stand for as an organisation, and we'll certainly be working with the executive to make sure that it gets the attention it deserves going forward. Marcia.
Thank you. Just a quick question around the Agile working program. So there's this huge piece of work happening in the background around how the future will look like for some, especially support staff. And I'm just wondering, is that something that's going to be featured in future agendas for the WWC?
It will. I mean, we've been talking to those Emma and David Hammond who are running the project called Better by Design, but this is really the arena in which future working models will be discussed. And I've talked with David about the need for him and the WWC to work almost hand in hand to make sure that we're comfortable with the operating models that are emerging are actually serviced well by all the functions that relate to it. So yes, absolutely crucial. And without, can I say, that Better by Design project is really unbelievably important to CCAM. I mean, without it, I think the WWC will be throwing up its metaphoric arms in despair. That really is the focus for the future of a great deal of what we're doing. And I think it's important that WWC work in harness with it.
Thank you.
Thank you. Are there any other matters before we move on?
Nikki?
Sorry, Nikki.
That's all right. I had a message from a member of staff regarding secondments. They were offered a secondment and it's been paused, delayed, not taken forward, and there's been no appropriate communication as to why it has been pushed back. It went as far as they were given a rota for their new position, and now they were told, don't bother, you're going to go back on the road, and now you're going to have to rethink what you need to do. So it sounds like their secondment was being pulled, but he hasn't actually been told that yet. And also there are 12 other employees that are saying that their secondments are in jeopardy because they've been told that they're paused, or possibly not going any further due to budget constraints. I just want to make sure that we're assuring ourselves that proper communication is being fed to those that are in the pipeline for secondments or have been given secondments, because if we're giving them out, why are we pausing them or pulling them without appropriate communication to those? I mean, I understand that sometimes secondments do get pulled back due to, change in circumstances, but are these employees getting the appropriate support? Because they're telling me that they're looking outside the trust now because they feel so disengaged with the whole process, which is sad to see so many good workers having to leave because they can't get the career opportunities that they're being offered here.
Nikki, it's a perfect example of what I was saying about the pressure on establishments and whether or not they're sustainable in the longer term. When you're saying secondment, you talk for this particular individual, you're talking about a secondment that was actually arranged somewhere else, set up to go.
Yes, so within the trust, so they're at the moment, and they were seconded within the trust to a different department, and now they seem to have been pulled with no explanation.
Okay.
Well, various explanations: budget cuts, pausing, recruitment freezes.
I'll go to Terry, but I'd like to come back to that if I may.
Yeah.
I'm just going to say that it's an operational matter that we're hearing one side of it, Nikki, from you, that secondments are always subject to the needs of the service, whether it's CCAM or anywhere else. So I'm just wary about talking about an individual who has contacted you when we don't actually know all the circumstances around it.
Yeah.
There are routes to go through for that sort of thing. Yeah. All I would say is that it's very operational, and secondly, to reinforce, secondments are only ever possible when the needs of the organisation allow them to happen. So I just don't want us to talk about operational stuff when we've only got one side of the issue. Yeah. I'm sure that person has spoken with his or her manager. And it may be offline. You want to make sure that the chief exec has got the details, but I'm not sure this is the forum for raising individual cases.
No, but what I'm saying is, I think are we assured that the communication is going out? Because if you're not communicating with people, then that causes frustration, and they don't know what's going on. So it's not.
What I think the secondments have been cancelled or set aside.
Yeah,
so
but then
there's other issues behind them, aren't there?
Yeah, but then they don't feel that they're being communicated with appropriately about those things. I think if they were told why these things were happening, they would understand. I think we all understand operationally that secondments are non-permanent positions and that they can be pulled at any time. And I think it's how we communicate with them as a team.
I don't agree. My point is simply you're reporting one side of a story from someone who has contacted you. And for all we know, they might have been contacted and they might not have liked what they heard. So I just think it's important that we don't just present one side of an argument in a meeting like this, which is a governors meeting. But I'm sure that that will be looked at outside of the meeting.
Can I ask that you supply details to Philip as Chief Executive, copy in Laurie, because I think there's a point, there's the specific issue which would be appropriate to talk, was not appropriate to talk about detail here, but there's the general issue about communication with staff. And one thing that I'm particularly strong about is that we shouldn't make promises we can't deliver. And if we can't deliver the promise, we need to explain why we can't do it properly. So, and I'd want to be assured there's a proper process in place to do this, and we're not misleading people. I think that would be wrong.
I mean, that's an important issue, David, and I agree entirely. And the other thing I'd say, Nikki, is that if you look at the work of the HR department now, one of the things that I think is going to receive more attention is the whole notion of career development. And I guess those secondments were part of a career development process. And to be really honest, the story you've told, I think, is quite really shows how important that actually is. Because if we don't develop the careers of folk in the system, then what they will do is look elsewhere. It's important that we enable people to develop to their full potential managerially and clinically, particularly managerially maybe. And I think you can be assured that the WWC is worried about that, not just because it's important for people and people's welfare and sense of well-being, but also because it's important to sustain a trained, educated, motivated workforce in the future. So that's something that
certainly wants to be progressed. Anyway, we're moving towards the end of this item. I think Harvey, you've got another question.
It was really to support what Laurie was saying. I observed the last WWC, and there was a lot of discussion there, which was around the real concerns that the changes in the NHS produce a pull out of CCAM, particularly for people like paramedics and equivalents. And we need to make absolutely sure that we are the place that they want to work. Part of that is how we develop them and how we communicate with them. So getting all of these things absolutely right is absolutely key for the future.
Yeah.
Point well made.
Thank you, Harvey.
Right. Any other questions from members of the council? So on the report from the Workforce and Wellbeing Committee and the deep dive. Marcia, do you hand raise again?
Yes, sorry. Just to go back to my question around the Agile Working Programme, I just received a message from a member of staff and I just want to clarify that I understood it correctly. You said that it's going to appear in future agendas. Will that include the new ways of working regarding corporate staff? Because obviously corporate staff are going to face huge transformation.
It's a really good point. We have a tendency, even within WWC, to talk about the front line as if, it's people in green out there looking after patients and communities. And I think we need to be very clear. We're talking about the EOC, and we're also talking about the corporate functions. And I think one of the big issues, and I mentioned it in relation to our organisational development agenda, is the relationship between the corporate functions, HR, finance, whatever, and the people providing those services. So yes, I'm not identifying just the people in active green. I'm talking about the organisation as a whole.
Thank you.
Good point. Thank you.
I hope you're reassured about that. Certainly into the future, I'm sure we're going to have more of a hybrid working, more of a mixture of using mediums such as this as well as in person. But whilst in person can have its downsides sometimes, particularly around in working environments, using this medium can also have its downsides as well, not least knowing who's got their hand up at one time when you're trying to chair a meeting. So there are some imperfections with our current ways of working, which we do need to iron out if we're going to learn from the past experiences of the last 12 months, for sure.
One final point, David, if I may. If governors want to attend the meetings, to observe the WWC meetings, we'd really welcome it. Colin and Harvey were there last time. Get in touch with me or Isabel, and we'll make sure that you're able to talk before the meeting so we can talk about the agenda. And then I find it very useful to pick up comments from the governors at the end. So it's an open offer.
Okay, thank you indeed. thank you again, Laurie. Very comprehensive report, and hope the council can take assurance from the detail in which the Workforce Committee is dealing with a number of very important matters relating to our staff and the safety of patient care. Okay, thank you indeed. Right, let's move on then towards the end of the meeting now. Have we any other business at all? Any other urgent business that's not been notified at all? Hence, we've cleared all the issues up. Thank you. And we're moving on then to questions from the public, item 2121. We've got one question that we've received from Frank Northcott, and good morning, good afternoon, Frank, if you're online. Frank asked for an update on his question about election boundaries that was taken at the previous council meeting. I understand this is going to be reviewed at the next Governor Development Committee, which will plan the September council meeting, which is usually held on the same day as our annual members meeting. So these changes are required to the constitution that need taking to the annual members meeting. We can plan them there. So that's what I understand is the answer to your first question, Frank. I hope that makes the point. It's still under active discussion. And your second question was whether there would be an annual members meeting this year, and the answer is I think we've already confirmed it will be yes, but we still to decide whether this is either going to be remote or face to face. I do hope it can be face to face, but we will be subject to practical constraints of what emerges from central government regarding particularly after 21st of June, how we can work in future. So we hope we can meet in person, but say subject to confirmation. Frank, I hope that deals with the points that you raised. Are there any other questions from those present at the meeting? That's all.
Philip, yeah, I'd just like to answer a couple of questions that I was asked earlier. So Jeff, you've spotted an error in a report. So congratulations, you win the bottle of wine. There were 33 incidents double counted, according to my statisticians. So well done for that. And it has been corrected. So your maths was right. And the second one about 90ths and means, which was, I can't remember who asked that, Harvey. It is right that the 90th, when performance is good answering the telephones, it's quite often the case that the 90th is lower than the mean, because there is normally one or two long calls, which makes when everything else is really short, like 1 second, when you add them all together and divide them by the number, the mean goes up, but the 90th is still at 1 second. So that's what's happened in this case. There are some calls in the last 10% that are longer to answer.
Okay, hopefully that gives you some assurance, Harvey. But again, thank you for asking the question.
Yeah, thank you.
Any other questions from the public at all? Okay, I think just moving on then to areas to highlight then to non-executive colleagues going forward. I hope you have got a good appreciation as a council of the work that non-executives are currently doing, and certainly of course the whole agenda pretty well covered, but there were a number of things coming out today I think needs to be some further attention to. Some I think matters of detail, which we've just heard some responses to just now, but I think there's a general theme around making sure that as we emerge from the COVID pandemic and we get back to more normal business, that we just look at our action lists and our promises that we made, just to check that our work plan is up to date and we're not left any loose ends in governance terms, which is clearly important. I think we will certainly, with your support, just continue to ensure this matter of public access defibrillators is well is well researched and tabulated, so CCAM is clear what it's responsible for, and those that we're not responsible for, we make it clear to other bodies, other public bodies, it is their responsibility, but we need to make sure we're working in partnership with that matter. And I do take the suggestions regarding the wider use of our CFRs to assure that process. And I think Philip asked you and the executive to take note of that in planning. The other theme which I think we take on board as non-executives will need to be continually discussed, I think, with the council because of your wide-ranging representation, is these our new way of working on you as we improve the way CCAM responds to demand, how we're managing increased demand, how we work in different ways, more agile ways, both in terms of our corporate staff, but also our frontline staff in terms of our clinical workforce. We do need to work in different ways. So I think that's certainly going to be a key focus on non-executive work going forward, to work in partnership with the executives, but also to make sure it's appropriately challenged on your behalf or on behalf of the public, that we get that bit absolutely right. And I think another theme that's coming through is a matter of genuine concern, which I hope we all share, is a matter of staff welfare and well-being, an area we can't be complacent about. But in terms of the sickness figures, I noticed what Philip was saying, how some are musculoskeletal, and clearly we do things there, but is what we're doing through the Wellbeing Hub appropriate in order to keep that number under review, the musculoskeletal injuries, but also the issues to do with the mental health of our workforce. I think is clearly something, as again we emerge from COVID, we all need to be aware of, both in terms of management, but also those that work to support management, to ensure that we're taking that matter seriously. Now, are there any other themes emerging out of today's meeting you feel I should be bringing to the attention of the non-executive team? So, Council, am I picking out the key issues there? I'm sure Isabel has a detailed note. Are there any other issues you feel you wish to emphasise? Certainly the education process, and Crawley College was certainly another that we picked up as well, just to make sure we're clear on that. Okay, well, if you're happy with that summary, can I just check in terms of meeting effectiveness? Are you happy that there's been appropriate openness and you've had a chance to have your say? Matters. In terms of timekeeping, we're probably banged on time, 2 minutes after questions the public started, so we're slightly ahead of schedule. So hopefully you don't feel that you've been shortchanged. Okay, well, can I thank you all warmly for attending, thank the public, and Frank in particular for your question, always appreciated, and I wish you all a good day. I think there'll be a short break, and those attending the part 2 meeting of the council will reconvene, I think, in about shortly, just after 1 o'clock, I think, 1 o'clock sharp, I think we should be able to start and conclude part 2.